Hi, everybody. I'm Courtney. I am a licensed therapist, and I've been doing these classes now um, for around 10 years. And North County Family Counseling Specialists have partnered with the district to do some of these classes for you parents. So thank you so much for being here and um, yeah, I am really excited about tonight's presentation. I am pretty passionate about helping parents, and so I am going to jump right in. The way typically that I structure this is I'm going to give you guys about 2 hours of information. I like to ask questions and answer specific questions that you guys have, whether it's tailored to you and your child or just the material in general. I'm looking for all of those questions, so please feel free. If you don't feel comfortable and you don't want to unmute yourself, you can throw any of your questions, comments, any of that into the chat because I check that throughout the presentation. So let's go ahead and jump in. Tonight, we're going to be talking about something that has been requested by many of our parents that attend these classes. And so this was a requested class from last series. And so at the end, we asked for feedback and people wanted to hear about autism and ADHD. And so I can kind of start with the caveat that I present from the lens of a psychotherapist. And so some of the material is going to lean more clinical and more medical. And the hope is that I can provide you guys with information to just give you guys all insight if you have kids or friends or you work in the schools or any of that. You can just get some information, solid information on these two clinical diagnoses in particular. And then I'm going to share um, a lot of like tools and tricks, strategies to help kids who are either on the spectrum or are diagnosed with autism spectrum disorder or ADHD, attention deficit hyperactive disorder. And that is going to be what we're talking about tonight. And I hope to just give you guys some information from a clinical perspective. So that kind of leads me in our objectives specifically. These are what's on the flyer that Annie sends out and when she's inviting everybody to the class. We're going to take a deep dive to help you guys understand more, a deep dive into autism and into ADHD. Again, from the clinical perspective that I have as a therapist specializing in adolescents and children for the last 15 years, we're going to learn a little bit about like overlap between the two diagnoses and also just like misunderstandings when it comes to these type of students or these children's behaviors or brains. We're going to, again, like I said, explore some strategies and techniques to help your kids at home and at school. And the final piece of this is really going to be tips on how to enhance emotional regulation and connection with these kids in specific. We'll have some question and answer time. Typically, I like to leave like 15 minutes at the end, although if we have lots of questions throughout the presentation and that doesn't leave us 15 minutes at the end, I'm okay with that too, as long as I get to answer questions that you all have. So that's kind of our plan for the evening. I do like to give a little bit of a background on who I am and where my expertise stems from, why the information that I'll talk about is credible. So I am a seasoned psychotherapist. I've been doing this just under 15 years. And yeah, I think the reality is that I've been passionate about helping parents with their kids, and this coupled with my experience and specialization in child and adolescent mental health really stemmed from my work with Rady Children's. I started working at Rady Children's Hospital when I was getting licensed early on in my career, and it really just um, it grew my passion for helping parents because obviously I saw a lot of kids, and so that means I saw a lot of parents. And my hope is always to give information and give strategies to help deal with some of these challenging things that we'll come across. I've worked in the San Diego school district, so I have a lot of time and work experience in the schools with kids and with parents, families, groups, and administrators and teachers, staff that work there as well. Yeah, I had some service in the United States Air Force, active duty, and I've worked inpatient and outpatient. I'm in private practice now. I do the parenting help as well in my practice. And so that leads us to today, which is thank you all for coming. Thank you guys for being open to the information that I have to share with you. We will get some feedback, hopefully, from you. If you enjoyed tonight, I hope you do. I hope you get something out of it. And you can tell us if there's anything you think we should add or take away. Okay, so jumping right in, we're going to start our deep dive into basically giving you a little bit of an understanding about the brain when we talk about the ASD and ADHD diagnoses. So, kind of what I like to start with is leveling the playing field to say, I want you guys to think of these types of things as kind of within the context of kids with a different operating system, right? So when we think about some of these neurological disorders or diagnoses, we can really think of this as maybe we're comparing it to like the typical operating system that might be Linux if you're using a Mac and it's Windows if you're using a PC. But the reality is that we have this kind of normative operating system. And when that's kind of how the computer runs, right? That's how our brain runs. Now, when we think about ADHD and autism, we're just thinking about this not as their brain is not broken, it's not functional, it's not less capable, they're not behind. We're really looking at this from a context of their operating system is just different than, say, the typical or yours, right? And so the idea is that we don't want to fix the child. We don't want to think of this, and this is kind of how this movement of the neurodivergent type of conversation came out of. It stemmed from this idea that in the medical community, a lot of things often were talked about as something's broken, we need to fix it. And that felt very unpalatable to a lot of people, a lot of patients, a lot of families, and a lot of kids. And so the way that this has kind of formed, and I talk a little bit about the neurodivergent thing specifically because that language, the concept of neurotypical versus neurodivergent, is not a clinical terminology. It is rooted in activism and the sociologist Judy Singer in the 1990s. And so this is a conversation that some of the activism has really started to change the way the medical community words things and how we talk about certain diagnoses. And so I want to kind of point that out just as the framework that we don't feel like these kids are broken. They're not something that needs to be fixed. And that's really kind of that language, the importance of that language is that we just remind ourselves that these kids are different, right? There's a different operating system, but they're still able to do many of the things that other kids or other people do. And so I wanted to kind of give that framework as a starting point. And if anyone has questions about that, like I said, feel free to ask, throw it in the chat. If you turn your mic off, I'll see you and know that you want to say something. But yeah, this has been really helpful, I think, for a lot of people just to feel like their kids, their kids are not broken. Their kids are not less capable. They're just different. And so it's a really beautiful way to encompass this conversation and really just help the kids succeed in schools. And that's really the lens that I take in the Virtual Parent Academy is a therapist's perspective on how this stuff shows up in school and how to help kids in the school context. And so I try to bring some of the stuff from home as well. And that's what we're working off today. Okay. So, one of the other things that I really would like you guys to take home today is it's really this conversation of like from this to that. And that's what this whole slide is all about. And really, what that is getting at is in the world of therapy, particularly with kids who might be typed as having extreme behaviors or negative behaviors, what we really want to help families, just people in general who interact with these kids, we want people to understand behavior is communication. And that is really helpful for us to understand that principle because then everything else kind of lays neatly on top of that. If we think of um, dysregulation, right, or kids who are unable to process their emotions, or they have like some serious meltdowns, or we see them as very reactive, um, this is not the same as disobedience, right? And while it looks like disobedience, right, what it's communicating is something else. And so that's kind of what I want people to get into the framework of thinking. What is my child's behavior communicating to me in this moment? Can I look beneath the behavior and read what's going on, right? I know my child. This is why I think a lot of us feel very confident that, oh my gosh, I know my kids are getting sick. I can kind of feel it. I can, I know them so well, or whatever, right? We can really read our children's behavior and decipher those behaviors because we know them so well. And if we look at all of this from the context of behavior as communication, then we see dysregulation not as disobedience, but as overwhelm, right? Or sensory overload, right? These things very quickly go from, oh, my child's being really disobedient and they don't listen, to he's very dysregulated, he's sensorily overwhelmed and extremely stimulated, right? This is causing emotional dysregulation, which is leading to this really extreme meltdown. And so that's kind of a good key reframe for us to think about. Dysregulation doesn't equal disobedience. Another one might be a kid who has struggles, right? Not necessarily, and that could be anything. That could be something like struggles to keep the room clean, struggles to keep his desk organized at school, struggle to turn in work on time, right? These things do not mean laziness, right? A lot of people are trying to interpret their child's behavior. And sometimes we get that. We come to the conclusion that, oh, they just don't want to try. They just don't, they just don't care. And the reality is, when we talk about specifically kids in the context of autism spectrum and ADHD, and I would argue children at large, when kids are struggling, it doesn't mean they're lazy. It means that their brains are either they don't have the executive functioning required for the task, right? Which we know kids' brain development doesn't really peak or stop. We used to say 25. Now I think we're leaning more with the research, new research coming out. It's more like 35. And so what we recognize is that the prefrontal cortex, which is the nice planner of the brain, the secretary of the brain, if you will, is inhibited in children and young people in general, but even more so when we talk about autism and ADHD. So, if we can really kind of go from this to that, right? Dysregulation and disobedience to overwhelm or struggles not equal laziness. It could equal lack of executive functioning or lack of training, right? Lack of skills. It really changes the way that we respond to our kids, the way that other people respond to our kids, the self-talk that our kids have, and many more arenas are impacted by that. But I think it's just really important to have that conversation and reframe the way we think about behavior before we ever even get started talking about all the other things that we'll talk about tonight. All right. So, this is where we will go into the clinical conversation of what is, and again, a clinical overview of what is the autism diagnosis. What is it clinically? And so, for a lot of people, the reality is that it's a neurodevelopmental condition and it has to be evaluated. I'll talk a little bit about the evaluation in another slide. But essentially, if you have a child and you think that they might be on the spectrum, or you think that there might be, um, some of these behaviors that we'll eventually talk about, the best thing to do is look for a neurodevelopmental evaluation. And like I said, we'll kind of get to that. These are not typically done by schools, but they can be. And so, what this means is the autism diagnosis is a neurodevelopmental condition that affects primarily social communication and interaction, patterns of behavior and thought, and the ability to sensory process. And so we'll probably go really in depth into social communication, interaction, and patterns of behavior and thought. These are some of the really specific diagnostic criteria that we utilize in the clinical setting. And it's really just to say we try to get the best picture of these behaviors in multiple settings, and we make a diagnosis based on those things. So, what I talked about is that sensory processing. Typically, what we see is sensory sensitivity. And so, we're going to kind of go through a lot of this criteria. You might see some of these things in kids who have a diagnosis. You also could see some of these things in kids who don't have autism or ADHD. And so, we'll kind of talk about the nuance to that as we get further into the conversation. Sensory sensitivity is typically characterized in kids with on the spectrum, characterized by sensitivity to sound and or texture. And so sometimes this is described as um, sounds feel really loud, right? Sounds feel louder, textures feel harsher, and we talk about like lights being brighter. People who are on the spectrum identify that pain sensitivity or pain tolerance or adjustment is impacted. We also know that sensitivity to temperature is different, right? This all goes back to the sensory processing parts of the brain. So, light, sound, temperature, pain, movement, smell, touch, really the wide array of this of all senses feel and are interpreted differently with a brain impacted by the spectrum, by autism spectrum disorder. And again, this goes back to uh, the neurological piece of the condition. It is structurally different in the brain. And so there are differences to these particular areas of the brain, leading to these different sensitivities, particularly with lights, sound, texture. A lot of times we find that lights and movement could be particularly interesting to children on the spectrum. And this is kind of one of the things that we look for in really young kids to kind of see, are they abnormally interested in light or movement? And are they really distracted by those things in the context of their environment? So it's something to kind of watch out for. Typically, what we see is that texture sensitivity. Clothing feels more irritating. We might find some kids have a lot of that sensory processing with socks or with the clothes that fit around tight parts of the body, the waist, the socks, the bands of pants. And so a lot of this is not that, again, this goes back to our reframe, not a child trying to be difficult. It's a child who has a brain that's perceiving those sensory elements differently and uniquely. And so in that, we really have to try to come up with strategies that work, that help these kids to feel those things less strong so that they can get through their day with minimal or less distraction than if we didn't do anything at all or we didn't understand it. A lot of people describe this as to kind of give us a little bit of context if the people here don't have autism spectrum disorder, you're not on the spectrum, or you don't have ADHD. Imagine living with the volume around you turned up to 200%, right? That sensitivity to noise, or the lights turned up to 200%, the sensitivity to touch or smell, those things being turned up to 200%. The reality is that it's perceived again differently in the brain. Sometimes we see with sensory sensitivity that children will like smell or touch objects. Either they're trying to smell it, sometimes they'll try to lick things, or they're kind of overly interested in the texture or smell of an item. And so we see that behavior as well. And that's really just more so interest in what's happening, right? Their brain is interested. How can I kind of make sense of this? It might feel overwhelming. It might feel just odd or different, foreign or novel. And so moving on to kind of some of the next characteristics, one of those things that we talk about clinically in autism is social interpretation differences. And you might find that kids who are on the spectrum, they have difficulty reading tone. They have difficulty reading body and facial cues. The reality is that the back and forth type of conversation is quite different. Sorry, guys. I had an emergency with my bathroom. It got locked, and I think they're trying to get in to open that. I'm gonna pause for just a moment, let them in to do that with the bathroom, and I'll be right back. I'm so sorry. Thank you. Sorry, I'm with the patient, so I'm gonna just go and leave this open for you guys. It just needs to be unlocked. Okay. I am so sorry, guys. Okay. It happens sometimes when you see kids in your medical practice, they lock the door in the bathroom, and then I had to go to the restroom and I couldn't get in. Okay. So social interpretation differences. What we really see here characteristically is difficulty, like I said, reading tone in the voice. Kids might be, I find that a lot of kids get upset because they think their parents are angry at them, or their teachers are angry at them, or kids don't like them. And so, because of that inability to read tone, body, and facial cues, they have a really difficult time, or a more difficult time having that back and forth conversation really easily with either other kids or adults. We find that kids on the spectrum have very literal thinking. And so there's less of that kind of like abstract, emotional type of thinking. And what we see is sometimes, not always, but more often than not, little or no interest in peers. And so we have kids who are very socially isolative. They have difficulties in play or making friends. Kids who are on the spectrum have a lot of difficulties understanding relationships. So the difficulty is in making and maintaining friends. That back and forth conversation is limited. They're having a really hard time interjecting or knowing how the typical conversation is progressing. And they really have a hard time understanding different social relationships, particularly difference in context, how I treat this person here versus here versus here. And so we find that kids who are on the spectrum definitely reduce sharing. And so we have to teach them skills to prompt them, learn how to share and how to learn to share appropriately given the context. We also find that kids on the spectrum, they have a strong difficulty in adjusting their behaviors for different contexts or environments, right? So you might have someone that you know at school, and then in another context, they're wary of saying hi, or they don't know how to necessarily react in that environment because it's different. It's a different context. So it's not that generalizability in the relationship or interpersonal skills. So another kind of key reframe in this particular conversation is that kids who are on the spectrum that have this social interpretation difference are not being rude, they're being literal or direct, right? And so they're kind of removing a lot of that emotional awareness that we kind of take as standard. And it's a very literal or direct translation of what's happening, what they're feeling, what they're thinking. And so sometimes I think this is a difficulty both in school settings and home settings because what we're used to in terms of discipline or what we expect from one kid will be drastically different because we wouldn't punish a child for being literal or direct or not being able to read the tone or the body language, the facial cues, but really just understanding that their brain is processing those social interactions very, very differently than our own. Okay. So another thing that we see clinically with autism is the need for predictability. And this goes back to the flexibility in any given context or situation. Flexibility is extremely limited typically. And this means that there needs to be the same thing, right? They're very insistent. Typically, there's some rigidity there with the sameness of a day. And really, what we look at that is the way to interpret that and a more kind of accurate way to interpret that behavior is again, not as being rude, being disrespectful, being difficult. It's that a routine for a kid who's on the spectrum equals safety. Right. And I'm not sure if some of you guys were here for some of my previous classes. In particular, we did some of the positive discipline talks on one of the most foundational needs for humans is to feel like they belong and that they're safe. And so we're kind of constantly, kids are constantly pinging their environment and their caregivers for that safety. And so when we have kids who are on the spectrum, that routine equals that safety, right? And so as soon as something is changed, it's a very big threat, right? When we think about it like psychologically, there's a psychological threat happening, even though we might not understand it that way, right? It's like, okay, everything's fine. We're not eating the same thing out of the same cup tonight for dinner. It's not a big deal. But in the sense of routine equals safety, we can see from that context how just frightening and destabilizing or dysregulating for kids on the spectrum that change in routine really is. So we do talk about the flexibility being very limited. There might be some ritualized behavior or movement. And this is, we look at things typically with kids who are on the spectrum who have uh, sometimes like obsessive type behaviors, right? There's this like ritual, repetitive type of behavior. It could be movements, right? Some people observe these things as movements or as routine behaviors. A lot of times what we see in terms of this need for predictability is also in the context of transitions, right? So from moving from one activity to the next, or moving from one place to the next, this is going to show up a lot in school, right? Because if you think about how many transitions there are in the day, the reality is that all of that is um, not the same thing, right? It's not that insistence or that rigidity on sameness. It's like constant movement, shuffling around, right? Different classes, different setting, different kids. And so what we do find is that most kids on the spectrum typically have a really large anxiety spike when we see any type of change. And I think one of the conversations to have here is also anxiety is a very strong co-occurring disorder when we talk about the autism spectrum diagnosis. It very often we see it occurs alongside some type of anxiety. And the reality is this, right? The change equals anxiety for a kid who has the need for predictability. And so if we can kind of think of it this way, again, this reframe is the routine and sameness equals safety, change equals anxiety, or change equals unsafe, right? Now, there's definitely ways to handle this because, of course, what we want is to help those kids understand that we can get them some sort of safety. We can get them feeling of a place, more of a place from safety if we teach them certain skills and strategies. And we'll definitely talk about what some of those are in the next conversations, next couple of slides. Um, One thing that I try to help families or parents or just people in general get the context for autism spectrum diagnoses is imagine just constantly feeling out of control, right? If you can look at something maybe in a situation where you have been at work or you have home life, where any particular situation that made you feel really out of control, imagine feeling that on a daily basis and not being able to really regulate yourself back to that normal baseline state. The reality is that kids tend to feel really out of control. Hang on just a second. I think I have some. It's good. Thank you so much. Have a good day. All right. We're not locked out of the bathroom anymore, guys. Thank you so much for being patient with me. Okay. So imagine that feeling of being out of control. That's what kids on the spectrum are really feeling when it comes to this characteristic of the need for predictability. If we really also think in context of understanding our kids' behavior, going back to that first slide, I really would encourage you guys when your kids have meltdowns and this is to be said also of kids who are not on the spectrum or kids who do not have ADHD or ASD diagnoses. Try to think of your kids' behavior as a message. What is their behavior saying to you? And how can we get to the deep root of the issue, right? So that's something, a little bit of a reframe in parenting in general, and even more so with kids on the spectrum or kids with ADHD. Okay, so we also see a very limited or intense, deep interests in very what used to probably have been called in the medical field as not necessarily bizarre, but kind of like out of context interests, right? You might have a kid who's never had any interaction with trains, and yet they're very deeply, intensely interested and quite exclusive interests, right? And so historically, this was very categorized as like, oh, these kids have these really like intense, exclusive, odd, interests. And what we're kind of reframing that again as now is that a lot of these things can become strengths later in life, right? You might have a kid who's deeply, intensely interested in trains, right? With no kind of clear indication where that would have come from or like, oh, why would that help? And yet, perhaps later, right, he becomes someone who is an expert on locomotives and can formulate some sort of, you know, innovation in that system. I don't know if any of you guys have ever seen the movie called Temple Grandin. If you have not seen it, I think it's on Netflix. Uh, maybe it's on Prime. I don't know. If you look it up, it's called Temple Grandin, and the story is really, really endearing. It's the story of a girl, now a woman, who was diagnosed with autism spectrum disorder very young in life, and she had this very deep, intense interest in cows and cattle. And the whole movie is really about this deep, intense interest for her. And they were very soothing to her. It really helped her regulate from time to time. And they go all into that in the story. It's based on a true story. And Temple Grandin was actually one of the people who totally reformed cattle slaughterhouses and made them more humane for the cattle and for animals in general. And so it's this idea that she had this really deep, what used to be categorized as
No,
strange
no, you
or
have to. Let's
unusual
start.
or odd interest, and yet that became a great strength for her. And so that movie's really great. It can kind of help you understand some of these points and really hit that stuff home if you've never seen it. It's also just a really wonderful movie, watching the story of Temple Grandin and how her mother really persevered and dealt with those trials in a really just kind of heartwarming, wonderful way. Okay, so this kind of goes back to that reframe that these kids are not being weird, they're not being difficult, they're not strange, right? They are literally sharing with us how they view the world and how they interpret the world. And because of the way that their brain works, right? They have these very deep, what we would call selective intense interests. And so we can highlight that as these can be a great strength for them later in life. Okay. So, what we're going to talk about now is this goes back to this idea of the autism on a clinic in a clinical perspective, but particularly behaviors to understand that are specific to kids who are diagnosed on the spectrum. And so this will be a little bit of that, like helping us understand what it actually is, versus that like communicated behavior. So, a lot of times with kids on the spectrum, we see them avoiding eye contact. And this goes back to that uh, sensory processing, not only the sensory processing, but the social interpretation differences, right? On this slide, we talked about lights feeling brighter. Lights or movement that can either be interesting or distracting. They're very sensitive sometimes to light and sound. And so when we have someone who's avoiding eye contact, this is sometimes read as disrespect, right? Or disinterest or checking out, or they're deliberately not listening to me or not doing their work, right? And what we really want to be able to understand is that this is the prime behavior that communicates overstimulation for a child on the spectrum. And what that means is they're trying to pull their focus off of the thing that's overstimulating to them and trying to offload that somewhere else, right? And so what we want to do is really try to communicate in our or just set that up in our own brains that the avoidance of eye contact is not communicating disrespect or disinterest. It's really just communicating their overstimulation and that inability to sensory process at a similar or effective rate that people not on the spectrum would or do. One of the things that we also want to help parents or people, other kids even understand is that the repetition of phrases or those kind of could be ritualized rephrasing of what somebody says, the kind of parroting or mimicking, echoing. That is what we don't want to think of it as like odd or weird behavior, something to really kind of stamp out or make them stop. What we really want to help understand that context is it's children, it's a processing strategy to help those children either remember certain things like rules or things that, processes that they go through, through doing a task from start to finish, or it's really just helping them understand what it is that they're being asked to do or told to do or expected to do. And so oftentimes when we hear kids who are repeating those phrases, we can kind of know immediately that that behavior is a way that they're processing the world around them or whatever it is, the task that they've been asked to do or the thing that they need to do on a daily basis. And so if we can think of it like that, instead of it being this weird, odd behavior that we have to kind of get them to stop, we can help them by saying, oh, okay, this is their brain moving, this is the brain working, and this is literally them trying to process what might come naturally to someone else. And this is the way that their brain is doing that. One of the things that I talk to parents who either have kids on the spectrum, whether it be the autism spectrum, or we also have the fetal alcohol spectrum disorder. And that's not something that I'm going to get into today, but within the context of both of those spectrum diagnoses, we talk a lot about or like encourage parents to understand that meltdowns are very different than tantrums. And what we want people to understand, particularly parents and teachers, people who are dealing with kids, working with these kids on a daily basis, is that the tantrum or the meltdown is a nervous system overload, right? Meaning their central nervous system has activated what we call the sympathetic nervous system, and that is the stress response, right? And so when kids have meltdowns, they're typically activated, their sympathetic nervous system is activated, which means they're not learning, right? They're not taking in new information. So we can't reason with those things. We don't want to use that as a teaching moment or like a lesson moment or a parenting moment. What we really have to understand about a true meltdown from the context of autism spectrum is, or like I said, the fetal alcohol spectrum diagnoses, there is no goal in a meltdown. Typically, meltdowns, they're not goal oriented. And that's how we can tell them the difference between a tantrum and a meltdown. Typically, meltdowns happen more often in ASD or FASD because of the parts of the brain that are affected by this neurological condition. And what we find is tantrums have a clear goal, right? And so you might know with some of your own kids when your child's throwing a tantrum. I have a toddler, she's 2.5, and she absolutely throws tantrums, right? Particularly when she doesn't get what she wants, or we say no, or she's wants something that is her sister's, or right. So we know that the tantrum equals I want this thing, or you didn't put it in the right cup, or right, the
Hey,
goal
nope.
is
Stop.
I want this particular thing that you're not giving me, right? So that's the goal of a tantrum. Now, with a meltdown, these things are typically happening because the central nervous system has been activated, the sympathetic nervous system is activated, and it's a stress response. So there is typically no goal. We can't really do anything to, like, we say your child's having a tantrum. Oh, I gave them the blue cup instead of the red cup. Well, I could just get the red cup and that will stop the tantrum, right? Meltdowns are not this way. Also, I guess as a side note, I would argue when your child has a tantrum, don't do the thing that will accomplish their goal, right? Because then kids eventually learn if I do the tantrum, my parent wants to fix it. So typically I would say we allow that whole tantrum to hit its peak and it de-escalates. And perhaps afterwards, we can kind of use some sort of modification to either change or, give them the red cup that they wanted. But we never want to use it in tandem with the tantrum, if that makes sense. Now, the point I'm trying to make in terms of autism is that meltdowns are not goal oriented. They don't have a desired outcome and in terms of the child. And so we can really understand this as it's the storm. We have to wait for the storm to pass, right? And there's not a lot we can do in order to de-escalate that because of the way that meltdowns work in the brain and because the central nervous system is activated. So my hope is that instead of solving that problem for you, because with kids on the spectrum, we typically don't see a nice solution to meltdowns. We might try to reduce the overload, the sensory overload, the overstimulation, right? Certain things that we know trigger meltdowns because those things are the kind of catalysts to the activation of the central nervous system. So you can kind of start to learn some of those and reduce those things. I would say screens are a big trigger for kids on the spectrum having meltdowns. And typically, what I say, kids on the spectrum and kids with fetal alcohol spectrum disorder, I typically remove screens altogether, or that's what I recommend from a therapy perspective, because they're affecting their brains differently. Their inability to manage that nervous system activation really leads to more meltdowns and more like quote unquote negative behaviors that parents really don't want. Oh, thank you, Annette. I really hope you guys watch that. I'm going to write it in here. The name of the movie is Temple Grandin. We had a parent who said, she's such a good example. Um, I agree. It was such a beautiful movie. I mean, of course, I'm crying at the end of the movie because it was just, it was really heartwarming and it was a really cool opportunity for, I think, um, people on the spectrum to like, for everyone else to recognize that these quote unquote weird things that kids do are not really weird. And it's just their brain's way of making sense of the world. And so I thought that it was really cool that Hollywood kind of gave that part of just that part of the mental health community like some understanding and some advocacy, which by the way, I believe, if I'm not mistaken, Temple Grandin is she's become a bit of an advocate and kind of a champion and really goes around and talks to people about autism spectrum disorder and like her experience. And it's a really beautiful thing to witness. So if you get the chance to watch it, please do. But don't blame me if you cry because I cried. But I cried a lot of those movies. So it's very heartwarming. Okay, continuing on. Let's talk a little bit in the context of autism. We're going to talk a little bit about the causes and risk factors. I'm not going to go too in the weeds into this. I'm sure, as a lot of us know, there's a lot of stuff that happens politically and with autism spectrum disorder, particularly maybe in the last year or two. And I won't go into any of that. Really, what I'm going to focus on is what we know from the research as of now. What I will say is that we need more research when it comes to autism spectrum disorder. We do know that rates are rising, and I've seen this just anecdotally when I worked at Rady Children's. I used to do triage, which is meaning just all the incoming families that wanted help for their kids. I managed the triage portion for the outpatient clinic in Oceanside for some time. And I saw such an uptick in kids who are on the spectrum. And so I really just want to say we need more research. And maybe if we have families who have that information and can advocate, for more research and just we all have that voice to say we need more research, then um, that is time well spent, at least in my mind. So I figured I'd go ahead and say that first. What I also will say is, in terms of the ASD conversation, uh, there's a very, very strong genetic or hereditary component. And what that means is 80 to 90% of autism spectrum disorder that we see is there is a hereditary link. Excuse me. So that's a very large chunk, right? That leaves anywhere from 10 to 20% that there's not a clear hereditary or genetic component. And there's kind of some nuance to that as well that I won't get into. But the reality is that with autism spectrum disorder, it is a very complex interworking between genes and significant gene mutation. And so what we do know, and so kind of this conversation of the way that we know that there's a genetic component is that there's a super high concordance in identical twins, right? And so that helps us recognize, and we do a lot of this when we talk about these research studies. When there's high concordance in identical twin studies, that really just means that genes are primary in that specific disorder or medical diagnosis that we're looking at, right? It just helps us understand from the scientific point that like uh, this is biological. This is a gene. There's a gene component. Now, I think we don't know all of the perhaps the rest of the 10 to 20%, right? There's something else happening in some of the cases or in a handful of the cases, right? Outside of genes or genetic mutation or outside of the hereditary component, I should say. And so, what that does mean is that we know that certain external factors during early pregnancy, there are some of those things pointing to this other portion of the ASD diagnoses. Some of those factors that we've really been able to establish with scientific research or empirical data, meaning it's been tested over and over and over again, right? Which is what we would need more research to do to figure out some of these other factors that we don't know of yet or know how the rest of the environment is interacting with early pregnancy or babies, right? We do know that increased parental age tends to be one of the increase in risk factors. So the older the parent at pregnancy or conception, right? Either the dad or mom, um, increased parental age is a risk factor. So it just means older parents, right? That's why there was this big, there's always kind of been in the medical community this discussion of geriatric moms, right? As they call us if we're older than 35, which is a little bit bonkers in my mind, but we're going to go with the science, which means increased parental age puts us at a higher risk genetically for autism spectrum. Prematurity, and what we also see is like extreme prematurity. Prematurity in terms of the baby when baby's born, right? Preemie babies have a higher rate of autism than non-premature babies. Pregnancy complications also, and again, I'm not going into super detail, and we that's probably a conversation for another time, but I've seen some research on vitamin D. I've seen obviously sunlight exposure, certain vitamins, certain toxins, things like that. Um, Flu in mothers or conditions in which they would have to take certain types of medication or yeah, certain medical interventions during pregnancy. These complications, right, are some of the risk factors. So we talked about genetics and hereditary component. We talked a little bit about the increased parental age, so older parents at beginning of gestation, prematurity, and particularly extreme prematurity, pregnancy complications as well. So kind of what I always end this with is we need more research, like I said at the beginning. And so this could prove to be super helpful with increasing rates. And yeah, just looking at all these factors and kind of trying to understand all of this, I think it would be very pertinent for us to do some more research on this particular issue. Okay, so what we have is diagnosis for ASD can come as young as 2 years old. We definitely are seeing earlier rates of diagnosis. And this obviously requires very thorough interdisciplinary evaluation, which typically means physician, we have neurologists, we have psychologists, behavioral therapists, speech, occupational therapists. Typically, we have all of these people, meaning an interdisciplinary team. These people do a very, very thorough and quite extensive evaluation, and this leads typically to a diagnosis. And there are a number of, I think, organizations that do testing. The last time I really needed to have all that information when I was doing triaging with Rady Children's, I know that that was the resources then were strained, and so I imagine the resources now are probably more than ever strained, meaning wait lists to get in, being able to find these things at an affordable or approachable cost. Does insurance cover it? Like these were all really big questions in the context of autism spectrum, even when I started doing this, 15 years ago. So I can imagine those things have maybe accelerated. I don't know if any parents here have any experience with that or any suggestions in terms of resources for families or parents or kids with autism spectrum disorder. Excuse me. And if you have any of that, please feel free and compelled to put that in the chat for the other parents. Um, Now I'm blanking on the name of the I don't know if Annie knows this. It was kind of the main I'm blanking on the name. It's been so many years that I was referring to this place. Regional Center down in San Diego. They were kind of our common referral for getting families, particularly who had with families who either don't have insurance or had insurance that wouldn't cover these types of things. Regional center was always a really good referral, also for like respite care and respite services, evaluations, all that kind of stuff. I'm hopefully not dating myself, and I hope that they're still around and doing those kinds of things. But that was always a good resource. I'll throw that. Um, okay. So, let's move on. I don't know. Here, I can pause. I haven't heard any questions, comments, feedback. I'll go ahead and pause for just a moment to answer any questions that you guys might have. Either let's do that about autism specifically, kids who are on the spectrum. Now, if you're hanging on for all of the tips and strategies, we will get there, I promise. I'm going to kind of go deep dive into ADHD and then get there. If anyone has any questions, please don't hesitate to ask. I love stopping and answering those. So, all right. I will keep an eye out for the chat for any questions. All right. Okay, we're gonna move into ADHD. What is ADHD clinically? We're talking about attention deficit hyperactive disorder, ADHD. This is also a neurodevelopmental disorder. I almost feel like I'm getting all tongue-tied. I don't know what's going on. Can I talk right today? Maybe it's the bathroom thing. I don't know. A neurodevelopmental disorder, typically what this is affecting is, despite the name, this affects regulation and not just attention. right? So the name, where it's kind of like, oh, is it ADD? Well, they did away with ADD, now it's ADHD, kind of this like, and then there's different types, right? So these things change in the medical community, but really what this is a neurodevelopmental condition. It affects regulation, so like emotional regulation, meaning someone's ability to manage and deal with whatever emotions come up or arise. Impulse control, right? Acting right away instead of being able to kind of wait. And that's that hyperactivity part of the diagnosis name. Attention, obviously, attention deficit, right? It impacts the ability to pay attention, to stay focused, particularly in non-preferred tasks, right? So there's an element of that as well. We also see big impacts in what we call executive functioning, right? And so that is all of that planning, all of that stuff that the prefrontal cortex is really working on in early childhood, kind of middle childhood, and into adulthood. That is the management of emotions, impulse control, attention, and kind of the secretary stuff of the brain. And so, one of the reasons why it's so interesting is this is predominantly affecting that prefrontal cortex, right? And so, that is all of those things like planning, long-term consequences, stopping and pausing before we do something irrational or impulsive, managing our anger or our despair when emotions arise, right? It's really impacting that part of the brain, which makes things pretty difficult, I would say. I have a lot of patients that I see who struggle into adulthood. I see a lot of adults who have ADHD, and there's a lot of emotional regulation impacts when they're older. Um, oh, Annette says this is the best presentation. I have to stop and say this comment. She says it's the best presentation I've ever heard on ASD. I wish I had it when my child was younger. Oh my gosh. Thank you so much. Thank you for being here. I'm really grateful for that comment. Thank you so much for the feedback. I'm glad you're here, and hopefully this helps another parent maybe who needs to hear this information. So, okay, thank you so much for that. All right, here, just like we did with the autism spectrum, we're going to do a little reframe, right? From this to that. And so, really, what we want to understand when it comes to ADHD, right? Just like we kind of did with autism, there's this kind of different operating system, right? Not a bad kid or a weird kid or a defective kid. It's just, right, the different operating system. It's like you run on Windows, I run on Linux, or vice versa, depending whether you're a PC or a Mac kind of gal or guy. And so when we talk about ADHD, we're also kind of saying that instead of having this kind of normative or typical based nervous system. With ADHD, we really have the interest-based nervous system, right? And I think that this is a really cool way of thinking of ADHD because I think so many kids and so many adults, right? They've just internalized these behaviors, right? Things where they're like, oh, they can't focus, like they don't pay attention, they're too hyper, they're running all over the place, right? Like they're broken, essentially. A lot of people who I see, particularly adults who have ADHD, also really deal with depression because of how negatively they've internalized the definition, right, of ADHD, all these behaviors where like they procrastinate and they feel like they can't get things done and they get this like task paralysis, right? Very distractible and kind of flighty. I think while not inherently negative terminology, I think that people really internalize that, and kids don't realize that they're internalizing that just yet, right? And so this is kind of the prime thing that I want people to go away from today is just like let's not let our kids internalize those behaviors and really like shame themselves, right? Instead of thinking like, oh, well, I can't focus and I'm just hyper and like I can't do anything right and I can't get with the program or like I'm lazy or it's like you're not any of those things, right? The reality is that your brain is having a hard time regulating your focus or regulating that impulse control, right? So if we reframe, these kids are not hyper and just wild and untamed, right? Their nervous system is different, right? It's like a different operating system, but it's a different nervous system. And so these kids, whether psychologically, physiologically, biologically, right? Their nervous system has really been born as an interest-based nervous system. So they have a really hard time regulating those things that like society tells us to do, right? Like, okay, you got to go pay attention and sit for 8 hours in this desk and learn these things, right? Like their brain just doesn't work that way. And it's really hard for them to regulate certain things, right? Going back to this slide where we talked about emotional regulation and executive functioning, attention, impulse, they can't regulate these things, right? It's hard of like when to be in charge of it and when not. I think that's the most crucial part of this is that their brain is operating again differently, so they're not able to just call upon the attention like someone who doesn't have ADHD and just say, okay, now's the time to pay attention, right? I'm learning this thing about trigonometry that I absolutely hate and will never use again, but I really need to pay attention, right? Like they can't regulate that. Now I would also say, and I want to really foot stomp this, kids, all kids developmentally, it's normal for all kids to struggle with every single one of these things, right? Attention, impulse control. You know those younger kids, they just jump, right? Or they just do the thing. They just go and say the mean word or, ah, right? Like they have very little impulse control. It's really hard for little kids to manage their emotions. You remember all those toddler tantrums. You might still see them from time to time with your older kids. I know you do, even teenagers, right? Even adults. But like these things I want to point out are very like they're developing and our kids we don't recognize it, especially teenagers. They look like little adults, right? You're big, you're tall, you talk like an adult, you look like an adult, but they're not, right? And their brains are really struggling to catch up to all these things because that's the natural way. Now then we have a child who's got ADHD for whatever reason, right? We'll get a little bit into that. And they're furthermore impacted by the inability to regulate these specific things. Okay. And so if we think about ADHD not as like these little wild children who can't sit still or, don't pay attention, we really can focus more on like their regulation of those skills is impacted and from a brain perspective, right? And so it's crucial that we understand it that way. It can be super helpful for us to reframe it that way and then teach our kids, look, it's not that you can't focus, right? It's that you're having a hard time regulating that focus and like, let me help you, right? And we'll get to all those strategies of how to help them. And this is not just focus, but it's not that they don't have any control. It's that they struggle regulating the impulse control. They struggle with the emotional regulation. They struggle regulating all of those like procrastination, when to do what, time management, right? Their brain is really struggling to regulate all of that. So if we can get that key reframe, I think that we're really going to be able to transform the way that kids like grow into this ADHD, right? Like I said, I see so many adults with ADHD. They've never understood ADHD. They've never been taught about ADHD in the what I consider appropriate way. And then they've internalized all those negative behaviors as this is bad about me and it means something negative about me, right? And it just absolutely doesn't. And this, we can say the same for autism spectrum. I'm just using this a little bit different when we talk about ADHD. So the same can be said of both, but I really want to help parents and help kids learn to not internalize these things because it's just terribly damaging. And they feel it as adults. And I think, whereas I said, kids who are on the autism spectrum typically co-occur with anxiety. More often than not, I see kids on with ADHD who become adults who co-occur with depression, right? And that's because of this like the way that it shows up. And I'll get into that on this slide. What is ADHD clinically, right? Inattention. So those kids are, or adults, we're talking about kids right now. They fail to give close attention to details. So a lot of people, and this is even written in the diagnostic, the medical language, careless mistakes, right? Now, when we say careless, we're not being punitive or we're not being nasty, right? What we're saying is there's a meaning behind this, and it is mistakes that could have been avoided, right? If the child was moving slower, if the focus was regulated and turned on, right? Then we're not making careless mistakes. So that's not to sound mean, it's just to say, if the child were to slow down, they would be fully capable, right, of doing that thing, which makes it careless, if that makes sense. So that's kind of why they use that language. And I just like to give that caveat because we don't want to call kids careless, right? Because I've never met a person, a child, an adult with ADHD who wants to have ADHD, right? They're not careless. They're not trying to do these things, right? Again, this goes back to that idea that, like, I've never met anybody who's like, yeah, I love my ADHD. It makes me so happy. I wish I could do it more, right? It's like, no, they don't want this. And so we can't label them as wanting this or kind of this like, they desire this thing and so they're careless or lazy, right? It doesn't fit. So, difficulty sustaining attention in play or in tasks, right? So, this is kind of when we're doing that diagnostic stuff. The characteristic is, do they have difficulty sustaining attention, not just with tasks in school, but like at home too? Like, what are they doing when they're playing, right? And this goes back to more of like a clinical, an expert's going to kind of like decipher all this behavior. But for parents, right, you might see that they really struggle even in play to like stay focused or stay attentive to one task or one play detail. They get kind of all over the place, right? So, um, we see kids who, the part of this inattention with kids who have ADHD, right? They don't follow through with instructions, right? And usually there's like a couple things missing, or they kind of skip through really fast, right? The reality is that either they fail to finish whatever project, task, instruction. They're highly disorganized usually, right? Whether we see like at the desk, there's just kind of like chaos in there. It looks like a little tornado. Disorganization is really hard, right? Because again, the secretary, it's like the secretary left the CEO for the day, and what happens, right? He falls apart. He doesn't have his calendar. And the joke of this is that a lot of CEOs have ADHD, and this is why secretaries are so popular, right? Because they can't do it all alone. And arguably, the CEO without ADHD or the person without it, we really struggle to do all of this by ourselves anyway. But that's kind of this like interesting dynamic is that this is all the secretary stuff of the brain. So they probably lose things, right? They lose items, they lose track of things, they might be distracted, or right, their kind of thoughts are jumbled. Typically refer to as like very flighty, right? They're kind of like thinking all over the place. They might be forgetful, particularly when it causes them some pain, right? This isn't just like, oh, I only forget about your stuff. I forget about everything, or I forget about things across the different or different domains, meaning at school, at home, with my friends, right, with work, all of that. Oh, cool. We've got um, there's an event this weekend, and it's an autism summit. 2026. Somebody shared. So there's a link for that. There's a promo code, which is awesome. Can't make it this year, but thank you so much for sharing. That's wonderful. I wish I could go to that. Maybe I'll try to write that down and I could try to go next year. That is really cool. Okay, moving on. So we talked a little bit about the inattention, right? Let's move on. Executive functioning, right? What I will say about executive functioning is that, again, it's all the secretary stuff of the brain, planning. So long-term and short-term planning. This goes into starting tasks. So this is one of the reasons why people who have ADHD, kids who have ADHD, they procrastinate, right? That's part of the executive function, which is to begin a task, right? Now, for us, or for some of you, it might be like, oh my gosh, that's so trivial. I can start a task, it's super easy. Well, this is where that prefrontal cortex, that front part of the brain, is really impacted with ADHD. And this is that central portion, right? So, procrastination, right? They wait until the last minute to do things. They're pushing, pushing, pushing. Maybe they don't do it at all, right? And so they're getting marked down at school. They're getting in trouble at home because they haven't cleaned their room, right? They're having a really hard time completing tasks. So not just starting them, but then maybe they start and then it's just like, oh gosh, like, right, I can't even finish this thing. Um, Typically we see executive functioning really impacted with long-term consequences and impulse control. So, long-term consequences is really tough because when we have somebody who has ADHD, and this is kind of where that little depression thing creeps in, is that we have kids or people who make behavioral decisions today, right? So, choices today. Okay, well, I'm just going to stay on my phone for a little bit more, right? Or I'm just, and by the way, people who struggle with ADHD or have a diagnosis of ADHD, addiction to video games and screens, oh, it goes through the roof, right? Okay, so if you didn't know that, if someone's got ADHD, we really recommend minimal to no screens, no, especially no video games, because their brain, right, this prefrontal cortex is impaired, and we don't want that particular higher risk of like addictive screen behavior. So, back to this, right? Very impaired decision making. Long-term consequences are affected by that, right? Like I said, oh, I could just keep scrolling, right? And then I never get to the task that I'm supposed to do because I don't really recognize how that will impact me later, right? I'm unable to kind of look that far. And so that's kind of that process of the brain to go, if I do this, then in a year I'm really going to be suffering, right? Because of this and this. Now, as I said, for kids in particular, this is impaired anyway. Kids are not thinking about long-term consequences. We all could raise our hand immediately and tell stories about your kids, how they're not focusing on the long term, right? So it's not abnormal. However, this is more impacted, right? So that's what we're going to see with kids with ADHD, their long-term consequences. They're thinking about it even less, right? Because of that part of the brain being affected or less functional, whatever we want to call it. Time blindness, this kind of goes into that long-term consequence, procrastination behavior. Oh, I'll do it later, right? But in a person's brain with ADHD, they're time blind because we really don't perceive that thing as real, right? And this is even more so with kids because we already have this issue with kids being able to decipher reality from fantasy, right? Which is why we have kids who, they watch an episode of Magic School Bus, of someone being untethered in space, and then they have nightmares about it for a week. Well, it's a little kids show, but here we are, right? It's the can't tell the difference between reality and fantasy, and this is why I always recommend for families that I see or work with or just people, limit what your kids watch, especially when they're young, because they have an impaired ability to decipher whether that's real or fantasy. And you'll see kind of some behavioral problems because of that, or again, internalization of thoughts or behaviors, and that kind of impacts us later as adults. But going back to this, I'll do it later, right? Oh, I'll kind of plan for that. Well, it's not really perceived as real. Not only because the long-term consequences are not there, but because they become very kind of blind to time, which really increases the struggle with time management. right? Oh, I'll do it later. Oh, I'll take the trash out later. I'll do that later. And then they never come back to it, right? And that's just that kind of impermanence of that reality in the brain. Okay. One thing that is not talked about enough when we talk about ADHD is the emotional intensity. You might have a kid who's diagnosed with ADHD or not, and you might be having some gut reactions to this presentation, and you might be thinking, oh, maybe I do like we do an evaluation. We talk to the pediatrician. Um, big reactions, right? Uh, Probably so big that it doesn't seem like it fits the situation, right? That really big reaction, really fast escalation. They go from 0 to 100 emotionally in seconds, right? They bring the emotional intensity. Now, what that is, right, is it's the inability for them to regulate the dysregulation of the emotions. It's big, it's fast, and they can't really control that, right? Now, this goes back to that key part of the prefrontal cortex. The prefrontal cortex, while not the sole part responsible for emotional regulation, some of that happens there. And so we have this kind of impact where something happens and the kid with ADHD just kind of like flies off, right, into this emotional intensity. I have a lot of adults, like I said, that I see, and you know, they might think that they have a personality disorder, or they might think that, they're bipolar, and it's really just ADHD drives emotional dysregulation. And if we can recognize that, right, again, kind of backtrack on all of that, like, you're broken, you're damaged, something's wrong with you. Nope, my brain is having a little bit of a harder time regulating that emotion and turning that part on, and we fill in the gaps, right? And that's kind of part of what treatment of ADHD does. And we'll get to some of the tips and strategies, but that is just helping kids manage that, right? Like, we can help be that nervous system. We can help be that prefrontal cortex. We can kind of sign up as their secretary to say, like, oh, whoa, wait a minute. Okay, like, here's what we do in that scenario, right? And you kind of feed them some of that until they get really used to it and they learn to manage that a little bit better on their own. Impulsivity. So this is super common, not just with kids in general, but in particularly with kids with ADHD. You're going to see that kids are acting before they're thinking, right? They're moving. It's that big reaction, that fast escalation that happens with their decision making, with their behavior. So we see kids who are likely getting in trouble a lot at school, right? Because they're so impulsive. We see this a lot. It's probably the number one complaint is, okay, they're just doing stuff, right? He's acting without thinking. He's just so impulsive. We have to gauge that amongst like normal typical development because kids are just naturally impulsive, and then kind of compare, is this abnormally so, right? Or atypically so. Lots of fidgeting, squirming in the seats, right? We see this obviously show up in school, especially when they hit that like first, second grade transition where they're having to sit for more, sit for longer. Lots and lots of movement. Sometimes we see escapism, right, where they're trying to get away. They're supposed to be sitting, they're supposed to be doing something controlled, right? So maybe they're walking from class to class and they're trying to escape, right? They're trying to run away. They're very restless, they're on the go, right? They have a really hard time waiting or taking turns, or they just can't altogether. They interrupt or intrude in specific scenarios or situations, like very rapid, maybe even flighty speech, right? We see this a lot as kids age, and without the kind of specific skill building or training, right? We see that kids really kind of they do these behaviors more and more. So we notice like as they get fifth grade, sixth grade, we're seeing tons of like interruptions, running, restlessness, right? Moving constantly, sometimes escaping. We'll see a lot more of that as they age. Okay, so this goes back to like some of the behaviors to understand. Just like we did with like the autism spectrum, we're doing a little bit the same way with ADHD. Um, Not doing their homework, right? If typically we would think of like a kid who's got ADHD, I hear this all the time from my adult patients. Their parents called them lazy, right? You're lazy, get it together, right? Go do your work, go do your schoolwork, go do your homework. You're lazy. And really what we want to reframe this to, right? The behavior of not doing their homework is very often not laziness. It's the overwhelm, right? The inability to manage all of that thought process, that cognitive process happening in the brain, right? And they're simply overwhelmed. I don't know where to start. I don't know which task to start. I struggle to start the task at all. Once I start it, I can't finish it, right? So there's this like really real sense of being overwhelmed. And so if we look at this less as lazy, more as like overwhelmed, we have fixes for that, right? We can help with the overwhelmed. Can we help a kid when we label them as lazy? Not necessarily, right? They've got to change in order to get out of that. Whereas if they're overwhelmed, we can help them. We can manage that. We can help reduce the overwhelm, right? uh, Kids who have ADHD and they're interrupting, right? Instead of them being disrespectful, we can really look at this as like, oh, their impulse control is lagging behind, right? They have a very impaired impulse control. He's not being disrespectful. He's interrupted 3 times, but he's really struggling to get his body and his brain to regulate that impulse, right? Wait until I'm called on. For a kid who has ADHD, it's near impossible. Not impossible because we can teach, we can, get the skills, we can do the repetition, we can get the visual aids. We'll get into all of that. But really, we're going to build in some of that impulse control, right? Messy room. Kids with a messy room. Well, this kind of goes without saying. Kids with ADHD or without have a messy room. My daughter, she's about to be 6, she her room just gets overwhelming, right? I don't know about you guys. When I walk into a messy room, I'm just like, oh, I gotta get out of here. Um, and the reality is, kids are learning this, right? They don't have that like attention to detail, organization. Okay, I should put this back after I get it out, or else I'm gonna have a huge, crazy mess, and then I'm gonna have to complain about it for 5 hours before I do it. They're not putting it all together, right? So with a kid who has ADHD, being more so, maybe having a messier room than normal, instead of thinking of them as careless, right? We're going to look at this and perceive this, maybe rename this as an executive functioning deficit, right? Their executive functioning is not working at the same speed. It's different. They've got a different operating system running. And it's not that they're careless. It's not that they're lazy, right? It's not that they don't care. Um, it's that all kids struggle with this, and particularly kids with ADHD struggle with this more. Okay, let's see, we got any questions? Anybody have any questions, comments, things that are specific to you, things that helped you in these situations? Please don't hesitate to share that stuff. Let's see. How would you address an accommodation for a student who feels overwhelmed? Address an accommodation. Andres, I'm not sure if you are asking in particularly like with school for a school accommodation. Um, For a student who feels overwhelmed, I mean, really, there's a lot of different accommodation. A 504 plan. Okay. Well, first, I would absolutely make that clear to the team. I would just go in there and or like email somebody and say like, hey, like, could we do an update? Like, I really am hopeful that we could get an accommodation. Um, Really struggling to turn in homework. Like, my child's feeling very overwhelmed. First, I would say like talk about it with your child. Like, what's kind of going on, right? You could give them some of the language if you're finding that they're having a difficult time like verbalizing or identifying what's happening when they're like not doing their work. But if we have a kid who's got ADHD and they've got a 504 plan, I mean, the team obviously is going to be there to help and absolutely can find out accommodations that will fit the context, whatever environment they're in. Every school is different. However, what I would say, when you have kids with particularly like who get overwhelmed easily, right? Maybe it's they get more time, right? They get more time in the context of a 504 plan or an IEP. They get a little bit more time to finish things. That is usually really helpful because it reduces the pressure, right? Of like, oh my gosh, I have to finish all of this right now. If I miss it, I won't get the grade. All those things. So we give more time. we might do, I think a lot of times what I encourage as a therapist. Now, I'm not the best person to talk to when it comes to accommodations for the 504 and IEP plans because I'm a therapist. They have a lot of the educational experts and the case managers are really good to talk to when it comes to like what accommodations specifically can we provide. But from the context of a therapist, I would say more time. I would say, do they have a what kind of visual trackers or visual aids do they have? And again, we'll get to this when we get down to more of the strategies and tips. But I would look at that. Like they need visuals of some sort. We need a calendar that we work with like daily with them or weekly to really get things visually oriented for them. It might be little notes, right? Okay, I break things down into smaller tasks and I have my little notes that I can post-it notes or laminated notes that we put on their desk or at their workspace at home or wherever they're doing the homework, right? We really visual aids, timers, all of these things work really good with ADHD particularly. But I hope that that's helpful. And then what I would say is like, if you're asking specifically how to address it, I would talk to the case manager that manages the 504 plan for your child at the school that they go to. Because Annie, she might come to my rescue or my demise and say that there's not a case manager on 504 plans, but I think there is, right? Just like an IEP.
I believe so. Yeah, and it varies by site. So if you have questions, I can help you connect with our special programs department, special education department.
Cool. Yeah, I mean, I've worked with special education departments over the years, and I rarely did see 504 plans though. So I'm not as familiar with those as I am with IEPs, but I'm almost certain that you'd have a case manager and you could talk to them. And that's where I would start with addressing accommodations. And I mean, the case managers are so wonderful. They're gonna have like lists of accommodations specific to the site that your kid goes to so that you're not coming here and I'm making all these suggestions and then they're like, well, we can't, we don't do that at our site or we have this, this, and this. No. So again, I would always look to the case manager um, because they're going to be super helpful. And that would just be like, if you don't know who that is, find the 504 plan. The case manager's name is going to be probably the prominent name on there because they manage those in the context of the family. So that's a good way to start. Okay, I hope that was helpful. Thank you so much for asking. I love questions. Okay, so here's a little bit of like the overlap. Overlap meaning shared traits or shared characteristics, shared presentation things that we see between autism spectrum disorder and ADHD. And this is just to kind of like give families, okay, well, maybe I see some of this and I don't see that. There's a little bit of overlap. And I will say, with most diagnoses, with a lot of diagnoses, there's some overlap. And so when we look at ASD and ADHD, sensory sensitivity is a big one. Maybe not the biggest, but a shared trait amongst both of those diagnoses is that sensitivity to light, noise, sound, texture, pain, temperature. And so just kind of like being aware of those things. Definitely emotional dysregulation. I would say that is probably the strongest overlap that we see between ASD and ADHD. And really it's a tough one because we're feeling feelings constantly, right? And if you ask your kids how many feelings are you having in a certain day, um, I don't know what the average is, right? I know the average number of thoughts we have, which will produce a lot of those emotions or kind of catalyze a lot of those emotions. But the reality is that our kids are feeling a lot, right? And the inability to regulate those emotions, both for kids on the spectrum and with ADHD, um, it's really critical that we teach these skills because it's one of the biggest things in my mind that these kids struggle with, and one of the things that people notice the most, right? So it's one of those things that they may internalize that we don't want them to. And if we can give them some of the skills, particularly with emotional regulation, we can help that a lot. Social struggles, both kids with ADHD and kids on the spectrum, right? You think about, we already talked about like the neurological differences that kids on the spectrum, like not reading the body expressions, the facial expressions, the tone, the verbal differences and change, right? And then we also have kids on with ADHD that they're not taking turns well, they're interrupting, right? They talk a lot, they're moving around, they're restless, right? They're escaping, they're doing certain things. So that means socially, right, they can sometimes be ostracized for some of those behaviors, right? So we see social struggles because of how they interact with other kids at school or at home or wherever. They're really struggling to manage that, specifically like we talked about, taking turns, waiting, right, being patient, that back and forth conversation, um, being interested in the other person's interest, things like that. Difficulty with transitions. Now we saw with ASD, right? There's this big like we said that the routine equals safety. Difficulty with transitions also, right? Because of the lack of impulse control, that lack of planning, and that like kind of flightiness, right? Kids with ADHD also struggle with transitions. And particularly, we talk about like memory, right? The ability to regulate focus, attention, and memory. Kids with ADHD really struggle with that. So transitions can feel right like, oh, I'm reset, right? I go to the next class, I completely reset, and I don't think about anything that I did before, right? Because now I'm trying to focus on the here and now with this teacher, this subject. Okay, now we're going to get into the home strategies. I have a kind of portion of strategies for home and a portion of strategies for school. And again, kind of relying on some of those people. If you've got special education, kids in special education, really relying on those case managers and kind of reaching out to them in terms of other strategies at school. These are going to kind of be broad suggestions and strategies that work from a therapy sense. Okay. So, home strategies, right? We already clarified for ASD and ADHD, the structure equals safety, right? We don't trigger that sympathetic nervous system if we've got that structure and stability, which means I'm always going to tell parents, this is like the foot stomper of my entire parental conversation, whether you have a child with ASD and ADHD or not. um Consistency, right? Being the same, showing up with the same rules and the same boundaries and the same structure, no matter how tired we are, no matter how stressed we are, right? Like doing those really hard things, because we know that structure equals safety. So lots of visual schedules. I like talk with a lot of my parents, like some form of planner, whether it's a planner on the wall for your child, whether it's a desk calendar for an older kid. We can even have like stickers, colors, things that we visually schedule our day or their day with. These are super helpful for both kids with ASD and ADHD. We really want predictable routines. So while some people stress that like there's rigidity with ASD specifically in terms of routines, we want kids to be able to predict what's going to happen every day. We call these in certain like therapy modalities, we call them rhythms, right? We do the same rhythm, right? It's like dancing. If anyone is a dancer here or enjoys music or dancing, right? There's a rhythm that we can stick to and it's predictable and we know what's coming next, right? It feels safer. It feels better. And so if we can give our kids a predictable routine, again, as much as we can do, because we can't control it all and we don't have the ability to control it all, but doing what you can with the routine that you have, making sure it's predictable, meaning try to make it the same, right? Um, I think some people are kind of flabbergasted with me when I tell them that my kids go to bed at 7 o'clock every night, no matter the night, and they are up at 7. So it's a 7 to 7, but it's predictable. They've known it and people ask me, like, how do you get this to work? And really, I had the blessing of having a wonderful, seasoned therapist who's worked with kids way longer than I have. She's brilliant, and I was friends with her before I had kids, and she stressed to me have a predictable routine for sleep and do it the same every day. We really don't waver, and so that's been really hard for our family because we can't do certain things, we miss out on certain stuff, but it was a priority for me for a predictable sleep routine for my kids. And so I'm just encouraging you where you can have a really predictable routine. Um, you have to use your best judgment and your due diligence on what you want to vary on and how you guys want to, approach that part of your life. But a predictable routine, particularly for sleep for my girls, has really helped. It's also helped my sanity because then from I put them to bed at 7 and I have a little bit of time to like do work that I have to catch up on, read a book, take a shower, spend some time with my partner, like whatever that looks like, do something that I enjoy, watch a show, scroll on my phone, probably the thing I want to get away from the most, but the reality is it's predictable. It allows me some of that routine. And this can go for any routine, not just sleep routine, right? We wake up at a certain time, we have breakfast, we get dressed, we go to school, we come home, we have a snack, we do homework time, and then we relax. And then we, put things away, we have dinner, right? It's kind of this like predictable rhythm of life. Now, if you're in a life where you're like, my life is not predictable at all, find the rhythm where you can, right? I'm not asking you to bend and warp space and time. Don't feel like if you can't do it where you can, right? Clear expectations. So the best strategies, right, are when we have kids, particularly with ASD and ADHD, we want to let them know where are the expectations? What are the boundaries, right? We've talked about this with them. We visually put them out, right? These are how we earn things. This is what happens this is how we don't earn things, right? If we do XYZ, we set everything out very clear. What we really want to do is reduce verbal overload. So what I try to tell parents to do is we set this up visually, right? Lots of pictures with families. When I work with families who have kids on the spectrum or with ADHD, we do a lot of like laminated sheets that it'll say, okay, when I get home from school, I have my snack. I go into my room and I do 20 minutes of homework. Maybe I have, 20 minutes of movement, and then I get ready for dinner, right? Wash my hands. And we have pictures for everything. So we would create like little laminated sheets or unlaminated, depending on what kind of crafty skills you've got. But we're like drawing pictures and writing all of this stuff out. Um, I told you guys in one of the chats I did this with my 5-year-old who really struggles with cleaning her room. I'm sure we all have this element of sameness with our kids. I broke down cleaning her room into little, one step instructions, and I put them visually on post-it notes, and we put them on the back of her door. And now when it's like it's easier for her to clean her room. It's like it worked, right? Now I'm gonna have to put those sticky notes back up because they get lost and they get moved. But the reality is we can reduce verbally, oh my gosh, you didn't clean the thing again. Now you're in trouble. You don't earn this by just visually putting it all out, having those things on the back of her door so that she knows exactly where to look. If she starts to feel overwhelmed, literally, I usually say to her, let's go look at the back of your door, right? Let's go look at the post-it notes. Let's go see what step one we can take. And I'll usually take it with her. If it's cleaning up the stuffies, putting all the stuffies in the bin, we do that first, right? And you can do this with any age. We just change the steps, right? And we really break this down into small steps. And I would encourage you, like, you might do a lot of hand holding here and walking the kids through each step until they feel like they've got this kind of system, right? This routine in place. Um, Typically, we talk about like timers, checklists, visual aids and cues. I use timers a lot, particularly with ADHD. Um, I think that the timer specifically can be like okay, let's do 3 minutes of whatever this undesirable activity is, and then we'll take a short 1 minute break. Um, let's do 5 to 10 minutes of this undesirable activity, and then we'll take a short break. Because what we find is that this visual aid of time can be really helpful because of that lack of time management in the brain with kids or adults who have ADHD. Um, so I would strongly recommend getting some of these things. There's tons of stuff. I don't know if anybody really likes to use Pinterest. It's one of the things that I use frequently for these like visual aids, and I'll just go in and kind of print things out and put them together or rearrange them in like a Word document. That can be really helpful as well. One thing that we talk about when we talk about like emotional regulation, and these are more home strategies. What we want to do is we co-regulate with our kids who have, especially who have ASD or ADHD. They are essentially borrowing our nervous system, right? Because our young kids do this. You might remember when our kids are really little, right? This is very similar to infants, toddlers, right? That really young childhood age. But it also is so with our kids who have these neurodevelopmental things, right? Which means we do the same thing. We co-regulate first. We might match their tone. We might get on their level. We might sit down next to them, right? We might actually use our hands and feet to assist, right? We're going to help them regulate their breath by perhaps starting a process. Okay, I'm going to start sniffing, smelling the birthday cake and blowing out the candles. And we might sit with them and model that, right? And if you find sometimes your kids, whether they're having a meltdown, we're just kind of waiting for that to peak and de-escalate, or whether it's just kids who need a little help co-regulating, really helping them match your breath, right? Sitting next to them, not necessarily looking at them, just sitting with them, helping regulate the breath, right? That's kind of where we want to go first because essentially, with kids, particularly with ASD and ADHD, we are letting them borrow our nervous system. And so, if we show up calm with a still, regular heartbeat, regulated breath, calm energy, right? We match their tone, we sitting with them, getting on their level, we're physically assisting or visually assisting. This really goes a long way when we start to talk about helping kids manage regulate their emotions at home. So this principle, if you guys haven't seen the positive discipline classes that I did, you can go back into the YouTube videos of those. Annie usually shares the link with us. If she hasn't already, it will be in the chat. You can go back and watch the positive discipline parent classes. And I talk a lot about connecting before correcting. And so that's a skill that's kind of the same thing. We want to validate the emotion, we want to name the emotion, particularly with kids who have ASD and ADHD, because they can't typically identify those on their own, at least not before we've given them the skills or kind of taught them the skills. So we always want to co-regulate first, and then we want to connect before we correct the behavior. And we absolutely don't want to do any of these things if our kid is in an active meltdown, because what we call their prefrontal cortex has completely flipped. We call it the lid is flipped, right? And they're unable to retain or absorb any teaching, any parental lesson, any words, essentially. We just need to kind of wait, sit that out, and wait until the tantrum or the meltdown concludes before we can actually do a teaching, have a teaching moment. So we talk a little bit about the school strategies, right? We want you to partner with your child's school. We were talking about this. It's kind of like we addressed this already with one of the parents. Um, Communication with the school first. If there's an academic plan, great. If there's not one, communicate with them. We can, if necessary, advocate for a 504 or an IEP plan. The special education department is going to be wonderful at handling that. I've worked with so many special education departments in San Diego County, and I have just met some of the best people in those roles. And so, yeah, I would just say communicate. If you've got a case manager, message them. I know Annie is a great resource because she's a parent liaison. She's amazing at what she does, and she's always here to help you guys communicate with the school and give resources. Um, some of the school strategies, like I was saying, is accommodations without giving you, so I can give you some specifics where generally I'm talking about like sensory and visual aid tools, particularly with kids who have autism spectrum disorder and ADHD. But the accommodations conversation is harder to have without knowing what site your child goes to because each site will have different accommodations that they can provide. And so that's just kind of broad like recommendations. And I don't want to go and give you guys any, presume to give you recommendations for accommodations. And then you go to the school and they're like, we don't have that particular thing. And so some of the basics are those visual aid tools, timers, kids getting more time or separate locations to do testing or specific school activities, all of those things, right? We talk about like school strategies, obviously, from my viewpoint as a therapist, I've done training in terms of clear instruction, consistency with the academic instruction and direction. And those are things that I can help with, right? And I do try to help with on a regular basis to help schools do that. So, giving you guys a couple of these tips in specific with some of the home strategies, we talked about emotional regulation. And I think that's one of the biggest ones that I like to focus on because I think this is the most detrimental if left um, like unhelped or unaided, right? I think that the emotional regulation piece is crucial. And this is what I want you guys to at least start with in terms of teaching your kids. The first would be that identification and verbalization of feelings. And these are things, I don't have one in front of me. I have one in my, probably closer to my therapy chair, where it's a laminated feelings wheel and maybe next time I'll include that as a link, but you can Google this really easily, like feelings wheel, or I have one with little faces, and you can get these easily off of Google or Pinterest where we just print it out and we help them by identifying and verbalizing their feelings. And this could look like a face, right? It goes from maybe the equilibrium of like a happy face, feeling great, smiling, to a very unhappy, angry, super frustrated face. And we just help them by like, okay, what does this person look like they're feeling, right? Or can you imagine when your face ever looked this way, or you ever felt this way? We're going to teach kids to identify and verbalize their feelings by saying, I feel mad. I feel frustrated. We might tell our kids, my body feels fast, or my body feels so slow, or my brain feels really slow, right? We're giving them language to understand those, what we call like somatic feelings, the body sensations. My brain feels really full, right? And we just want to help them do that by giving them the language and teaching them. Um, what I will say is when we talk about emotional regulation, right, kids need, this was like the foot stomping point, they need safety, they need consistency, and recovery and progress is far better than the daily behavior, right? Because what we want to help kids understand, this goes back to that internalization of all of this, kids getting better, each small little movements is so much better than the kind of behavior that we see every day, right? We don't want them to feel labeled by that overwhelmed outburst or that meltdown that happened because they were sensorily overstimulated. What we really want to focus on is how much progress have they made when I first started, from when I first started teaching them how to identify their feelings. And so if we look at it that way, wow, we've come a long way, right? And really giving them that language as well. This is not about what we're failing to do. This is not about us being broken or damaged or not good enough or that we need to be fixed. It really just means that we're growing, right? We're progressing. We're learning these things. Our brain's learning how to regulate things better. And really, we can use this stuff on a daily basis and be that accountability partner for our kids, that secretary part of our kids' brains that they're really impacted by, to kind of help do this with them. I will say some of the best regulation tools, we talk about like time, right? Timing certain things. Sometimes I give kids timers and just say, okay, we're going to sit for 30 seconds and we're going to take nice, big, deep breaths through our nose and out through our mouth, right? So we're timing the regulation, giving them now it might not be 30 seconds that they can do right in the beginning. It might be 5 and then it might be 10, right? And we might have to build up to that, but we're going to use time in an incremental way and kind of an encouraging way to say like, oh my gosh, you did 5 seconds every day this week. Let's try 7 or 8 or 10 next week. um, we might also use quiet. We might also use like very unstimulating environment. We might go to a nice quiet place. We might turn the lights down. We might turn all the noise, all the movement down. That quiet and stillness can really, really help with the emotional regulation of your kids. I think modeling this stuff too by taking that, like, I'm going to take a minute to sit here and breathe, or I'm going to take, 5 minutes in my quiet, dark space or my quiet, dim space, right? Breathing, we talk about like diaphragmatic breaths, and I try to teach that to all my kids, meaning get them to lay on the floor with maybe like a bowl of treats on their stomach. And what you're going to try to do is get them to push the stomach out while they're breathing up and down instead of using the chest or the lung area. That's kind of the initial training for diaphragmatic breathing. Movement is a really good one. We talk a lot about like pushing, pulling, heavy movement for kids who need emotional regulation because these body movements really help. Sometimes just running, playing, being outdoors, lots of heavy, big movements can help. And I would just say like you gotta use your best judgment on this. Sometimes really fast, lots of movement can actually stimulate the sympathetic nervous system. Usually it's more like heavy movements, pushing big things, pulling things, climbing. That type of like bigger gross movement can actually be better for kids like this. Okay, we're running out of time, but I am almost there. I think we did really well. Some of the key takeaways that I want you to take from today. Key reminders are behavior as communication, regulation or connection before instruction, or connection before correction is another way I like to say that. Structure reduces stress. Connection builds trust with our kids and it builds the relationship, which is something that I talk about in all my classes. I believe that the relationship is the foundation to parenting, and progress over perfection. We want to really foot stomp that, especially with our kids, to let them know that they are making progress, and that is the most important thing. Here is our contact information should you need us. There's a link if you guys would. Am I seeing that right? Yeah, there's the survey, the anonymous survey to give us some feedback in the chat, and then there's a copy of the presentation. Thank you guys. I was getting close to the end, but I appreciate all of you so much for coming, and I hope you guys learned some things. I hope you enjoyed it. Let me know if there's anything that I can change or add or take out. And please fill out our feedback form. It really helps us kind of gauge what you guys are looking for, what else we can do for you.